Welcome to Grand Rounds for William Beaumont Army Medical Center. I'm Brian Davis, and this week I'll be talking about music therapy. Before we go much further, I'd like to make a few fairly standard disclaimers. The first is to make sure to remind everyone that the views expressed in this video are my own and do not reflect the official policy of the hospital, the Army, or the federal government. Furthermore, I have no conflicting financial relationships that I need to disclose before proceeding with the video. I first became interested in music therapy while a medical student. During one of our neuroanatomy lectures, our professor described the typical Parkinsonian tremor as 4 to 6 hertz. As soon as he said that word hertz, I created a new association with electrical and music theory, since that was the first time I had heard the unit of measurement hertz outside of those domains. During his lecture, my professor, who is himself a serious musician, used several other musical terms. Sometime afterwards, I approached my professor with what I thought was a very novel idea. During the lecture, he had said that patients with certain movement disorders eventually lose a natural cadence. His use of the word cadence had made me curious as to whether these patients might then be susceptible to an external cadence from music. Would perhaps music with a fast tempo make a Parkinsonian tremor worse, or could slow music make it better? He replied that there hadn't been enough time to go over it in class, especially as it wasn't testable, but that there were music therapies that helped patients with Parkinson's, although the relationship between tremor and tempo wasn't linear. I walked away feeling like my eureka moment was a little behind the curve, and soon was swept up in the constant barrage of new information that comes with being a medical student. I didn't think much more about any of this until later this year, when people at work started talking about a video then circulating online. I'll let the clip speak for itself.
I have one resident that barely opened her eyes. She didn't respond. As much as I tried, I knew her for 2 years. No matter what I tried, massage wouldn't work, nothing worked. But when we got introduced to the iPods and the family told me the things that she liked, it was amazing once we put the iPod on her. She started shaking her feet. She started moving her head. Her son was just amazed. Okay, can we stop? Because now I'm getting all I'm seeing her all over again.
Hi, Papa. Hi, Papa.
Huh?
How you doing?
I'm all right. Fine. Wait.
Who am I?
I don't know. Wait a minute. I don't know.
Okay, it's Cherry. How long has he been in the nursing home? Approximately 10 years. He was having seizures, and my mother couldn't handle him at home. Of course, it affected me greatly because he was always, fun-loving, singing, every occasion he would come out with a song, no matter where he was. I remember as a child, he used to walk us down the street, me and my brother, and he would stop and do Singing in the Rain. He would have us jumping and swinging around poles. He was, he was good. He was always into music, always loved singing, dancing.
His name is Henry Dreyer.
Uh-huh.
And I'm looking more or less for religious music for him.
Okay.
Because he enjoys music and he always quoting the Bible. So I'd rather have that for him.
We first see Henry inert, maybe depressed, unresponsive, and almost unalive.
Henry.
Yeah?
Henry.
Yes, y'all.
I found your music. You want your music now?
What do you want me?
Let's try your music, okay? And then you tell me if it's too loud or not.
Then he is given an iPod containing, we know, his favorite music. and immediately he lights up. His face assumes expression, his eyes open wide, he starts to sing and to rock and to move his arms, and he's being animated by the music.
And he used to always sit on the unit with his head like this. He didn't really talk to much people. And then when I introduced the music to him, this is his reaction ever since.
The philosopher Kant once called music the quickening art, and Henry is being quickened, he's being brought to life.
Yeah.
I'm going to take the music for 1 second, okay? Just to ask you a few questions. Okay? I'm going to give it back to you.
Uh-huh.
Okay.
The effect of this doesn't stop, because when the headphones are taken off, Henry, normally mute and virtually unable to answer the simplest yes or no questions, is quite voluble.
Henry,
Yeah.
do you like the iPod? Do you like the music you're hearing?
Yes.
Tell me about your music.
Well, I don't have none, I mean.
Do you like music?
Yeah, I'm crazy about music. You play beautiful music, beautiful sound. Beautiful.
Did you play music when you were, did you like music when you were young?
Yes, I went to big dances and things.
What was your favorite music when you were young?
Well, I guess, Cab Calloway was my number one band guy I liked. They did the holy, the holly, the hilly, the holy, the milly, the holly, the ah.
What was your favorite Cab Calloway song?
Oh, I'll be home there for Christmas. Oh, you can count and plan on me with plenty of snow, mistletoe, present wrapped around your tree. Ow!
So in some sense, Henry is restored to himself. He has remembered who he is, and he's reacquired his identity for a while through the power of music.
What does music do to you?
Give me the feeling of love. No man. Figure right now the world need to come into music, singing. You got beautiful music here. Beautiful, oh, lovely. And I feel the band of love, the dream. The Lord came to me, made me holy. I'm a holy man. So he gave me this sound. I'll just say, I meet you. Let me see. Rosalie, won't you love me? Rosalie, won't you be sweet and kind?
With this beautiful new technology, you can have all the music which is significant for you in something as big as a matchbox or whatever. And I think this may be very, very important in helping to animate, organize, and bring a sense of identity back to people who are out of it. Otherwise, music will bring them back into it, into their own personhood, their own memories, their own autobiographies.
That clip was from a 2014 documentary titled Alive Inside, which examines the relationship between music and memory, especially in those with progressive dementia. It was voted as the audience favorite at the Sundance Film Festival that year, and the full 77-minute film can be rented on YouTube for $2. In the clip, we're also introduced to the famous Dr. Oliver Sacks, who himself wrote an entire book devoted to music and medicine, which chronicles the accounts of patients with various music-related neurologic conditions. It proved a fantastic introduction to the subject and led me to eventually seek out a music therapist.
The most basic definition of music therapy is the use of music to achieve non-musical goals in an individual's life. So we're there to use music to achieve anything non-musical. It's great that if you make progress musically, like for instance, if I teach you how to play the guitar, my goal is not to make you the best guitar player as a music therapist. My goal is to increase fine and gross motor skills, increase cognitive functioning. I'm focusing on those aspects of music rather than, oh, he learned an A chord. That's cool. Another technique we do is when you have problems with gait following a stroke or a traumatic brain injury, it's called rhythmic auditory stimulation. And for gait training, a lot of folks will have trouble keeping a steady gait. They'll have an arrhythmia in their gait, where instead of just being step, 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 instead you'll have like step, 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 step. And what rhythmic auditory stimulation does is you find what pace they're walking at currently, set that to a metronome, then back it down, usually 10 or 15 clicks. And then you'll design a series. You'll often pair this with another intervention called battery sensory enhancement if they don't have the right skills, where you'll design a musical intervention. Let's say they're not lifting their leg up high enough. So you'll have a musical intervention to work on bringing the leg back up before that. But once you get that, you set a series of clicks and you try and guide the patient into stepping onto the clicks. And the way it works is the motor cortex is linked to the auditory cortex, and just having that auditory stimulation will improve gait almost instantly, but it does take time to get to the desired level after that. The ISA principle is you meet a patient where they're at, match it with music, and then you bring them down or up to where they need to be. Because the body will match breathing and heart rate to music if it's close enough. Like if my heart rate right now, let's see, what is it? It's at 86. If I played a piece of music at 86 beats per minute and then gradually speeded it up to, let's say, 100, my heart rate would probably follow up to close to about that. And the same goes with breathing. If I would play a piece of music, I would see your rate of breathing, let's say you're going kind of rapid, and I match that. Eventually your body would start matching the music, and then I would change the music just gradually, and then eventually you would return to a more regular sense of breathing.
This is even if a isn't conscious.
Yes. In hospice, end of life, I had a patient that was unresponsive. It was, towards the end. And I was with my supervisor, we were playing one of his favorite songs, and he started tapping his toe. Like, he's totally unconscious, unresponsive, he's just breathing, he's in the later stages of modeling, reaching his end, and we started seeing him tap his toe unconsciously. And the rate of breathing and everything changed as well, so.
Due to the current public health situation, it wasn't possible for me to observe a music therapy session in person. I was, however, able to find a YouTube channel dedicated to music therapy called MEMADE. I'll share a few of their clips to demonstrate some of the therapies that Michael talked about earlier.
Try it again.
I'm Peter. I'm Peter. I'm Peter. How are you? How are you? Hello, I'm Peter. How are you? I am good. Thank you. How are you? You are my sunshine, my only sunshine. You make me happy when skies are gray.
It's not difficult to imagine some dissenting voices, even in this spiritual crowd, saying something along the lines of, this is basically just good physical therapy and speech therapy, and there is certainly going to be a lot of overlap. But for the best outcomes, it would make sense to have an integrated approach. I think that there is a good argument to be made that there are unique benefits from music therapy. Things tend to be a lot easier to accept when there is a reasonable physiologic mechanism, in this case, neurophysiologic. The effect of music on Parkinson's patients is perhaps the easiest to approach. At its most basic level, Parkinson's is a failure of part of our brainstem, specifically the midbrain, known as the substantia nigra. It produces dopamine and interacts with structures in the basal ganglia and then directly with the motor cortex. The interaction between these centers on the generation, coordination, and eventual execution of motor activity has been described by two competing pathways, the direct and indirect. The direct pathway, in broad terms, promotes movement. Dysfunction of the substantia nigra significantly limits the direct pathway and therefore leads to typical Parkinsonian hypokinesia. In contrast, we have the indirect pathway, which, in broad terms, inhibits motor activity. This is critical for appropriate motor control and is one of the major reasons of conscious or executive control of movement. If you will forgive the imperfect analogy, imagine if the predictive text function on your phone was allowed to send messages without you keying in the text or pressing send. The movement sequence generators in these motor pathways are constantly active. Conditions such as Huntington's disease, where the caudate is damaged, lead to uncontrolled movement by disrupting the indirect pathway. The substantia nigra is also involved in the indirect pathway, and this partially explains why Parkinson's has both hypokinetic, such as the shuffling gait and micrographia, and hyperkinetic, such as the tremor, features. Unsurprisingly, these pathways and others related to movement have a great deal of interaction with other parts of the brain. Most of these are well beyond the scope of this discussion, but certainly relevant is the input of the association cortex, which relies heavily on sensory input such as the auditory cortex. In simple terms, this provides an alternative input to the complex milieu of the motor pathways, and in some patients helps to entrain and reinforce these pathways by engaging parts of the temporal lobe that otherwise wouldn't have much impact on the movement. This is, of course, neglecting to discuss the impact of feedback information from the primary somatosensory cortex on movement, but that is once again outside the scope of this talk. It's not difficult for me to imagine a few dissenting voices from the back saying, "So what? What does this have to do with me anyway? It's all outpatient stuff and probably most useful for a TBI clinic or for a neurologist working with movement disorders. We do very well just to get PT, far less a music therapist. What would they do anyway other than sing Kumbaya to try and keep people from sundowning? I'll stick to my Cinemet, thank you very much." Well, to those folks, I would like to sing a song of your people. Please, for the love of everything holy, if ever I am hospitalized and unable to make these arrangements myself, go and get me a pair of noise-canceling headphones and put on some good classical music. I don't care what I'm getting in terms of sedation. Noise in the hospital, especially in the ICU, could be its own grand rounds talk. But in parting, I would like to draw your attention to a small RCT currently underway at Mount Sinai, examining the effect of having a trained music therapist assist with vent weaning. Thus far, the only other studies have been simply using pre-recorded music. Even this showed improved heart rate and respiration rate before and after the therapies, which did not involve a certified music therapist. I think most of us have watched patients experiencing anxiety related to vent weaning and have wished we could offer more than sedation to help them. I have high hopes that this trial will show benefit. Music and medicine are both profound parts of my life, although sometimes it feels as though they are on diametric poles. This talk has provided a welcome opportunity to examine the interaction between the two. Thank you for your time and attention.